Hello, everyone, and welcome to this audio podcast. This audio podcast is part of a Erythropoiesis edition. This audio podcast is part of the Hurricane Plexar. This audio podcast is part of a Labonix Vendip. This audio podcast is part of a Storm Robotics production. This audio podcast will have a sort of a review or an overview of immunosuppression in immunosuppression and regimens or regimes owing to solid organ transplantation, and also owing to where this series where this audio podcast series sort of generally delves into the importance of reduced nephrotoxicity or toxicological profile in immunosuppression, to see sort of prognoses, see sort of better prognoses in pediatric recipients or young recipients who may have who may have who may have had a solid organ transplant. And this audio podcast this audio podcast will although be in around immunosuppression, looking at immunosuppressants and immunosuppression, and sort of in line to sort of nephrotoxicity. There will be a basis where the where the where the remit or the basis will be in around sort of immunosuppression aligned to renal the renal or nephrology specialty. So solid organ transplant recipients depend on multiple immunosuppressants or immunosuppressive regimens given or administered in combination to prevent or preclude rejection of allografts. Um, these recipients often require many other therapeutic or these recipients may require other therapeutic regimens to treat underlying illnesses or concurrent diseases. And wherever a new medication or where new therapeutics are administered, the potential exists for increasing or decreasing tissue concentrations of immunosuppressant agents. This can lead to serious complications such as over immunosuppression and infection under immunosuppression, and acute rejection or additive toxicities, including nephrotoxicity. Transplant pharmacotherapy pharmacotherapy um, uh, uh, gen, has whilst has sort of developed and advanced, new agents or novel agents are investigated and improved for use. Clinical immunosuppression has been plagued at the same time been plagued with maintaining a balance between rejection rejection of a transplanted solid organ transplant, and complications of over immunosuppression, including infection and malignancy. Clinicians or specialists must understand current immunosuppressive or immunosuppressant regimens and associated effects when caring for solid organ transplant recipients. And whilst all transplant patients or recipients receive some form of immunosuppression therapy, the combinations and choices increase as novel drugs or regimens are developed. So in the critical acute setting, newly transplanted recipients will likely receive induction therapy. And the goal of induction therapy is to increase the prognosis, a prognosis that is synchronized or synchronized aligned to the patient, to the recipient and prognoses in around the allograft, and while preventing or precluding and or reducing rejection episodes. Several agents have been available for induction therapy, and each transplant unit designs its own procedure, designs its own sort of procedure, and the foundation for maintenance therapy rests on the combining of immunosuppressants to prevent rejection through a variety of pathways. An understanding of the mechanism of action and additive effects of a drug allows professionals to optimize therapies whilst decreasing adverse effects. Immunosuppressive therapy offers potential for reducing detrimental recipient outcomes, and improving allograft survival. And it is well established that repeated rejection episodes have correlated with poor long-term allograft prognoses. Challenges facing researchers and investigators have focused on the improved patient outcomes and options to address sort of the constraints in around solid organ transplantation, sort of more sort of pivotally. Medication or therapeutics have been one of the major concerns in the nephrology specialty, and it's beginning to and it has become more complex as more drugs or therapeutics or pharmacotherapeutics are introduced into the specialty, in particular anti-rejection therapy for pediatrics or pediatric recipients. And because of nephrotoxic substances are enhanced because of nephrotoxic substances can enhance one's immune complex, compromise part of the immune complex. There is concern of sort of there are concerns of sort of some of those sort of additional illnesses including vascular problems or vascular abnormalities. The more common types of medication or therapeutics will be discussed throughout, and at the same time why nephrotoxicity is an ongoing sort of conundrum. To understand nephrotoxic drugs and associated abnormalities, investigations in specific topics of pediatric nephrology for the in around the pediatric nephrology specialty was one of the approaches that had taken place, and it was essential it was an essential basis to give a better understanding of nephrotoxicity. Thus, any information, including obtaining experimental data and research in around after suitable after a suitable MHC donor is also highlighted, will also be highlighted. So in both disciplines of nephrology, i.e. pediatrics and adult nephrology, one certainty is that the recipients can be treated sufficiently. Although this is a very although true in the pediatric recipients, difficult or is a challenge for treatment to aid a pediatric or a young person, because the tests and investigations unfortunately tend to be more frequent, thus interfering with schooling and academic performance. At the same time, specific medications and therapeutics for pediatric renal recipients have many toxicological profiles and affect the well-being of recipients. And so, again, just the objective of this works as part of this series was to establish whether renal allografts in pediatric recipients can have a prognosis of between 10 to 20 years post transplantation with the aid of immunosuppression or immunosuppressive therapy, and at the same time ensuring a sort of that there is reduced toxicological profile. This can be achieved because at the same time owing to the sort of differences in the differences in the at sort of immunobiological level, there this also prompts investigators and researchers, and encourages researchers and investigators within areas of pathology, but also within, for example, the pharmaceutics industry or pharmaceutical industry, to seek out sort of those components in those components as part of immunosuppressive agents or therapies, immunosuppressive therapies, to ensure prognoses. So during the past decade, several new potent immunosuppressive agents or immunosuppressive regimens with different modes of action and with different side effect profiles have become available. Nowadays, immunosuppression post-renal transplantation is no longer a one sort of single regimen applicable to all recipients. In the selection of optimal immunosuppressive regimens, individual drug-related toxicity, recipient-related risk factors, as well as donor organ characteristics have to be taken into account. Hopefully, at the same time, this works will give an overview, or this audio podcast will give an overview of the most sort of some of the most utilized and sort of retrospectively developed immunosuppressive agents and regimens available in the clinical environment. The individual mode of action and different efficacy and safety profile will be described as a basis for selection of each of the different regimens in an attempt to understand the impact of toxicity sort of in pediatric recipients. So the pharmacokinetics of immunosuppressive drugs, for example, cyclosporin A or CSA, tacrolimus or FK506, mycophenolate, mofetil or MMF, and sirolimus rapamycin are complex and unpredictable, or have been evidenced as being complex and unpredictable. A narrow therapeutic index requires a narrow therapeutic index unique to each recipient, as well as a variable absorption, distribution, and elimination are characteristics of these regimens. And therapeutic drug monitoring, or TDM, plays a main role in helping sort of nephrologists or specialists to maintain blood and plasma levels of immunosuppression regimens with respective respective therapeutic reference ranges. Variations in concentrations outside of the narrow therapeutic ranges can result in adverse clinical outcomes. TDM ensures that concentrations are not too high or not too low, and thereby reducing the risk of toxicity or allograft rejection accordingly. Therapeutic monitoring of immunosuppressive regimens has been based on several choices of assay as well in context of laboratory medicine and biological fluid. So, for example, whole blood and plasma appropriate for a particular drug. High performance liquid chromatography (HPLC) retrospectively remains had remained sort of the gold standard among assay methods used to monitor immunosuppressive drugs. Although HPLC is the assay of choice for CSA, newer monoclonal assays are suitable as well for sort of routine monitoring. HPLC is also widely used for TDM of mycophenolic acid, sort of the active metabolite of mycophenolate mofetil, or MMF, and an immune assay in European sort of retrospectively in European centers had been developed. TDM of tacrolimus had been improved with the recent more recent development of assays with greater sensitivity and specificity for FK506 than those previously or retrospectively available. No commercial assays are or had been available for the therapeutic monitoring of sirolimus. However, in literature now, there may be some perspectives from investigators and researchers in regard to, for example, molecular methods to identify appropriate therapeutic monitoring for sirolimus. It is also important to identify a specific pharmacokinetic parameter, for each individual individual regimen, whether it is for example trough levels or area under the concentration time curve, which may be one of the most helpful sort of tools or useful tools for optimal TDM in clinical practices. With an increased understanding of the pharmacokinetics of immunosuppressive regimens, TDM guidelines will be or have been sort of have prompted sort of a basis to ensure ensure the safe and effective management of transplanted recipients in context of paediatrics. Um, sorry, context of pediatrics and adult recipients. Um, since CSA or cyclosporin A and now a little bit in some aspects around some of the histories around around some of the therapeutics. So since CSA was introduced into clinical practices in the early 1980s and specifically in around 1983 to prevent allograft rejection in transplanted recipients, and the number of transplant centers, an increase in the life expectancy of a transplanted organ, and substantial decreases in rates of acute allograft rejection and life-threatening infections. Um, uh, despite the successes, major improvements in immunosuppressive therapy are have still been sort of warranted or required, especially a reduction in around the nephrotoxic sort of nephrotoxic profile of some of what are referred to as the sort of mainstay immunosuppressive regimens. Such improvements may be achievable with incorporation of novel drugs such as tacrolimus or tacrolimus, FK506 and mycophenolate mofetil MMF. Suffice to say, at the same time, tacrolimus, FK506, and mycophenolate mofetil MMF are also sort of no longer novel regimens. These two regimens or drugs are also somewhat retrospective as well. However, tacrolimus and mycophenolate mofetil MMF into immunosuppression protocols or protocols and the development of rigorously defined TDM programs. New immunosuppressants are under or have been under development in clinical use, such as sirolimus or rapamycin. But again, sirolimus is now is now in the generation of therapeutics or immunosuppression or therapeutics, almost in the same sort of generation, if you like, as sort of tacrolimus. It wasn't long after tacrolimus being available for use in solid organ transplanted recipients that sirolimus also sort of followed as well. At the same time, important interactions of drugs with immunosuppressive agents used in transplant important where novel immunosuppressants are still under development and in clinical use, and thereby creating the possibility of many thereby potentially prompting sort of many drug to drug interactions. Important interactions of drugs with immunosuppressive agents sort of are part of have been documented, have been evidenced and documented in context of pharmacotherapeutics within solid organ transplant specialties. The preferred modality for renal a little bit in sort of looking at sort of the preempt to the use of immunosuppression as well. So the preferred modality for renal replacement therapy is and has been evidenced as transplantation or renal transplantation, and its superiority in prolonging the longevity in pediatrics or pediatric recipients with end stage renal disease, and retrospectively, for example, in the United States, more than 12,000 renal transplants were performed in sort of 19 in the late 90s and 1988 to 43,000 in 1999. Economically, transplant is more feasible or more viable modality of renal replacement therapy, and an important factor when considering sort of general aspects around the specialty. In many countries where children or pediatrics or young people suffer more because of limited equipment, specialists and technicians trained in sort of dialytic techniques are relatively scarce or have been scarce. Transplantation remains the only option, or remains sort of one of the main options. And in terms of quality of life, pediatric surveys have indicated pediatric surveys or pediatric databases and sort of epidemiology works have indicated that transplantation is a better choice over other renal replacement therapies. Considering hemodialysis, this is not a long-term replacement for a kidney, and although there is the option of a transplantation in pediatrics, pediatric medication prescribed or therapeutics prescribed and induced causes many side effects, can cause many side effects, and thus the development of anti-rejection therapy with reduced side effects is necessary post transplantation. And this audio podcast will there will be a bit some more in around this a little bit later. All drugs can induce nephrotoxicity if a sufferer has renal insufficiency as well. Cyclosporine and tacrolimus are associated with drug-related nephrotoxicity or impaired renal function as measured or where biomarker creatinine is used to determine or estimate glomerular filtration or GFR, and also electrolyte imbalances. Early investigations reported nephrotoxicity as a major side effect of tacrolimus-based immunosuppression therapy. The European FK506 multi-center liver study group reported significant increases in the incidences of impaired renal function and oliguria for tacrolimus treated recipients in comparison to CSA cyclosporine treated recipients. A comparison nephrotoxicity was also reported on a more frequent basis with tacrolimus treatment in the United States multi-center tacrolimus investigational study, and resulted in a greater percentage of tacrolimus patients being withdrawn from the study. This was compared to CSA cyclosporine treated recipients. Although the mean glomerular filtration rates and serum creatinine concentration remained relatively similar between the two therapeutic groups, therapeutic cohorts. The studies report the investigations report serious tacrolimus induced nephrotoxicity, which largely attribute to the administration of intravenous tacrolimus therapy, resulting in the recommendation that this therapy should be avoided, especially in pediatric recipients. And at the same time, the immunosuppressants immunosuppressants or immunosuppression are drugs are therapeutics that are both primarily nephrotoxic but also cytotoxic, used to suppress rejection in solid organ transplanted recipients, and are used to aid a variety of and also are used to aid a variety are also used in the use of varying related immune relating disorders or diseases. So, for example, cyclosporin A or CSA was originally an antifungal metabolite, but it was found to have immunosuppressive effects without being dangerous towards other tissues in around pathophysiology. The CSA was also sort of a in the 1980s was a major breakthrough in the field of immunosuppression by workers in microbiology laboratories of an organization known as Sandoz, based in Switzerland in the early 1970s. A group of scientists had found strains of fungi isolated from soil samples produced metabolites that showed marked immunosuppressive effects in murine-based models, and it was where T cell interactions and cyclosporin or CSA prevented T cell interactions, and again inhibited cytotoxic T cell recognition and combats allograft rejection. At the same time, the CSA was evidence to have worked better with the use of a treatment therapeutics known as prednisone, and where the combination had better overall therapeutic indices. The active metabolite, a cyclic peptide, was isolated, and the names cyclosporin or cyclosporin A or CSA, CSA was part of what was given. Work in animals in animal models also showed that CSA was able to prolong the survival or prognosis of renal transplant, producing overall survival prognosis rates or survival rates than those obtained with azathioprine. It was where in works by Carl and colleagues also demonstrated a similar immunosuppressive effect in human beings as well. The clinical use of CSA, however, has been associated with adverse side effects, including nephrotoxicity, hepatotoxicity, and neurotoxicity as well. So nephrotoxicity is also is at the same time at the same time and sort of retrospectively had been difficult to distinguish from allograft rejection, and is a particular issue in the setting in around renal transplantation. Minimizing CSA induced nephrotoxicity can and could improve long-term allograft prognoses. However, to obtain significant long-term improvement in renal allografts, it may be necessary to utilize novel immunosuppressive regimens. Uh, since its induction into clinical practice, a CSA a novel formulation of CSA, which had been referred to by Sand Immune, had considerable impact on the outcome in around transplants. Three types of renal dysfunction had been observed in the use of CSA. None of these had been specific, but all have been present more commonly following CSA administration than in other situations. First, in recipients with prolonged oliguria and anuria post transplantation, the kidneys or the pathophysiology around the pathophysiology of the renal tubules may diffuse interstitial fibrosis, where the interstitial fibrosis has been evidenced as where there's a sort of an interactive toxicity that takes place. Second, acute toxicity, which is dose related and is less common now than now that lower initial doses of CSA and drug regimens have been implemented, and may be accompanied, however, by structural abnormalities if change may be accompanied by structural abnormalities if changes are present. They compromise a toxic tubulopathy. The third type of CSA induced a renal lesion is chronic toxicity, and this chronic toxicity associated with either striped or i.e. radial interstitial fibrosis and or an arteriolopathy. Mechanisms underlying in simpler terms, in simpler sort of terminologies, the initial dysfunction of the kidneys occurs post transplantation, usually in a kidney damaged by ischemia, where there is a stopping of or inhibition in around blood flow. The second type may occur at any time after the first 2 or 3 weeks, and is associated with deteriorating renal function, i.e. what had been referred in literature as chronic renal failure. It is usually associated with higher CSA levels and responds to a reduction in dosage. The third is chronic, where chronic is chronic and is also steady. It is associated with histological signs of severe interstitial fibrosis, i.e. nephrotoxicity. A study from Germany examined the efficacy of CSA plus low dose prednisone in 28 paediatrics aged between 2 years of age to 16 years of age, and reported actuarial allograft prognosis rates of 100% at 3 months and 96% at 2 years. In comparison, actuarial allograft survival in recipients receiving azathioprine and prednisolone was 68% at 2 years. A further important finding of this investigation was that in growth rates post transplantation was significantly higher in the CSA cohort than those treated with azathioprine and prednisolone. Many drugs or therapeutics have been reported to interact with CSA. Such interactions generally arise from additive sort of toxic effects, toxic effects. So, for example, nephrotoxicity again and hepatotoxicity, or from interference with hepatic enzymes concerned with the metabolism and excretion of CSA, particularly cytochrome P450. CSA is metabolized in the body by a hepatic enzyme system, cytochrome P450, and the latter results in alteration of plasma or whole blood CSA concentrations. Care should be taken, particularly in pediatric recipients. Medications that interacts which has associated nephrotoxicity cause more medical problems in recipients taking CSA. Had been reported in recipients taking CSA. The most commonly occurring side effects of CSA included dose-dependent and reversible renal dysfunction, hypertrichosis, gingival hypertrophy, abnormalities in around arterial blood pressure, hepatic dysfunction, hand tremor, and gastrointestinal disturbances. Renal dysfunction is the most serious of the CSA side effects. CSA has resulted at the same time in short-term improvement, but the long-term survival of pediatric recipients with renal failure had not been sort of reported or evidenced sort of retrospectively. At the same time, since 1988, there had been a substantial increase in the short-term and long-term prognoses of both living and cadaveric donors. In around the long-term prognoses of both living and cadaveric from cadaveric donors. On 25th of March 1984, a substance was discovered. A substance was discovered in a soil sample taken at the foot of Mount Tsukuba, which stands just outside Tokyo. The substance given given the name tacrolimus or FK506 or Prograf was found to possess a powerful suppressive effect on interleukin 2 production and interleukin 2 receptor expression, and based on the evidence at the time. Based on the evidence at the time, the tacrolimus was able to block initial T cell activation, inhibiting the differentiation and proliferation of cytotoxic T cells, and speculation about the substance's immunosuppressive effects grew. Um, there's a sort of a famous illustration in works by in works by Stanislaw Stepkowski, and where the illustration demonstrates that both CSA and FK506 antagonize calcineurin activation in the cytoplasm. CSA binds to its immunophilin, cytophin, forming a complex between CSA and CPN. CSA and CPN complex binds and blocks the function of the enzyme calcineurin, and which also has a serine or threonine phosphatase enzyme activity. Calcineurin fails to dephosphorylate the cytoplasmic component of the nuclear factor of activated T cells, and thereby transport of nuclear factor of activated T cells to the nucleus, and binding to the nuclear component of the nuclear factor activated T cells. FK506 binds to FK506 binding protein, or FKBP, forming an FK506 FKBP complex, which binds to and blocks calcineurin. The FK506 FKBP and calcineurin calcineurin complex inhibits the activation of nuclear factor of activated T cells, thus preventing its entrance into the nucleus. CSA and FK506 also antagonize calcineurin activation, leading to the inhibition of the nuclear factor of activated T cells. Nuclear factor of T cells supported and interleukin 2 gene expression as well. FK506 but not CSA acts more distally by attenuating the response of cytokine stimulation, possibly by altering the expression of high affinity receptors and or through antagonizing a main step in cytokine receptor signaling. Another form of CSA, cyclosporin microemulsion, was developed to overcome the pharmacokinetic limitations of the original CSA formulation to provide greater and more consistent drug exposure, as has been well documented, or as has been documented. The administration of CSA microemulsion results in significantly improved bioavailability with more consistent exposure of the drug in pediatric renal recipients in comparison with the original CSA formulation. This is carried out by comparing percent coefficients of the intra-individual variability for area under the curve of CSA and CSA emulsion to that of tacrolimus. Despite the pharmacokinetic differences, the safety and tolerability of the two CSA compositions are in literature have been evidence as being comparable. Works by one team have demonstrated that superior pharmacokinetic characteristic of CSA microemulsion had led to more efficient suppression therapy in early post-transplantation. at the same time, although there is marked improvement in around anti-rejection therapy or rejection therapy therapeutics, um, the question still remain the question still sort of ponders, is, are the toxicities reduced? Simply in a regard, the answer is actually no, unfortunately. And tacrolimus um, Tacrolimus or FK506, as an immunosuppression therapy treatment, um, acts by a variety of different mechanisms, which include inhibition of calcineurin, and it is used as a therapeutic alternative to CSA. Therefore represents a represented a sort of a cornerstone of immunosuppression therapy in solid organ transplanted recipients. FK506 is also has been established for primary immunosuppression in liver and renal transplantation, and experience with its use in other types of solid organ transplantation, including heart, lung, pancreas, and intestinal, as well as its use for prevention of graft versus host disease in allogenic bone marrow transplantation, is rapidly or has been rapidly accumulating. Large randomized non-blind multi-center studies or investigation conducted in the United States and in Europe in both liver and renal transplantation have identified similar patient and graft or allograft survival rates between treatment groups, and a consistent statistically significant advantage for FK506 or tacrolimus with regard to acute rejection rate. In general, a similar trend in overall efficacy had been demonstrated in a number of additional clinical trials comparing tacrolimus with CSA with cyclosporin based immunosuppression in various types of solid organ transplantation. Tacrolimus had also demonstrated efficacy in various types of transplantation as rescue, and what had been referred to as rescue therapy in recipients who experienced persistent acute rejection or significant adverse effects with CSA-based therapy, whereas cyclosporin or CSA had not demonstrated a similar capacity to reverse refractory acute rejection. A corticosteroid sparing effect has been demonstrated in several investigations with FK506, which may be useful consideration in pediatrics. Receiving renal transplants. The differences in tolerability profiles of FK506 and CSA may be an influential factor in selecting the optimal treatment for patients undergoing solid organ transplantation. Although both drugs have a similar degree of a similar basis of in around nephrotoxicity, CSA has a high incidence in effects such as hirsutism and gingival hyperplasia, and some types of neurotoxicity. So, for example, tremor, paresthesia, and also where alopecia had been evidenced with use of CSA. Tacrolimus a further with tacrolimus at the same time inhibits T cell activation, although the exact mechanism of action retrospectively had not been established. In literature more recent literature, for example, there may well be, or there has been, there may well be some reports, some novel insights into the mechanism of action in context of tacrolimus, in context of tacrolimus, more so. Experimental information, however, as aforementioned, at least suggests that tacrolimus binds to the intracellular protein known as FKPB12, and the net result is the inhibition of T lymphocyte activation, or i.e. immunosuppression. Prograf can cause neurotoxicity and nephrotoxicity, particularly when administered in high doses. Again, children or paediatrics have to become tolerant, or the immune system of pediatrics and children have to become tolerant to therapy, and care should be taken to in pediatrics receiving tacrolimus and other nephrotoxic therapeutics. In particular, to avoid nephrotoxicity, immunosuppressants should not be used simultaneously unless children or pediatrics under renal care under nephrology or pediatric nephrology are to have those clinical reviews. A lymphoproliferative disorder related to Epstein-Barr virus infection has been reported in immunosuppressed organ transplanted recipients. The risk appears to be greater in pediatrics, in young pediatrics who are at the risk of primary Epstein-Barr virus infection, whilst immunosuppressed who are switched to tacrolimus following long-term suppression therapy. Oversuppression of the immune system causes susceptibility to infection. Thus, anti-rejection therapy has to be used with caution. Drug interaction studies drug interaction studies sort of retrospectively had not been carried out, whilst there have been clinical trials around varying therapeutics varying therapeutics. The interactions had not been sort of carried out or conducted. This also means that pediatrics with renal failure could have drug-induced nephrotoxicity from secondary treatments or therapeutics, where from secondary therapeutics are also somewhat common. Initial clinical experience with co-administration of Prograf or FK506 and CSA resulted in addictive or synergistic nephrotoxicity. Many types of medication or therapeutics in different categories increase nephrotoxicity. Tacrolimus is metabolized by special enzyme systems. Substances known to inhibit these enzymes decrease the metabolism of tacrolimus, which result in increased whole or plasma blood concentrations. Some of the therapeutics have been evidenced or documented in literature around immunosuppression. At the same time, some drugs, some additional drugs that can, some additional drugs or therapeutics that could increase tacrolimus sort of blood, whole blood or plasma concentrations. So, for example, calcium. For example, there are three main categories. There's calcium channel blockers, there's antifungal agents, and there's macrolide antibiotics. So in around the calcium channel blockers, there have been reports, for example, that diltiazem, neocardipine, nifedipine, and verapamil as calcium channel blockers can increase FK506 or tacrolimus blood concentrations. Antifungal agents such as clotrimazole, fluconazole, itraconazole, and ketoconazole can increase tacrolimus blood and plasma concentrations. And in around the macrolide antibiotics, erythromycin, and trollidinomycin have been linked to increasing blood concentration levels, tacrolimus blood concentration levels. Yes. At the same time, there are drugs or therapeutics that can decrease tacrolimus blood concentrations, thus implicating or negatively implicating the general trough level of blood concentration, thus to prevent or preclude tacrolimus, for example, being potent or efficacious. So and there's two main categories in around the drugs that decrease tacrolimus blood concentrations: anticonvulsants and general antibiotic agents. So anticonvulsants such as carbamazepine, phenobarbital, and phenytoin can decrease tacrolimus blood concentrations, and antibiotic agents such as rifabutin and rifampin can decrease tacrolimus blood concentrations as well. So in around some more bases around some history context around these immunosuppressants. So there have been development of reduced nephrotoxic drugs, nephrotoxic drug for 5 or 6 years, at least retrospectively, when at least two of the main drugs, two of the main therapeutics have been developed. Originally described, however, in 1975 as an antibiotic of the macrolide, the same as FK506 family. The immunological activity of sirolimus or rapamycin was reported in 1977 in a rodent laboratory model. However, it was only recently, or it was it. However, it had. However, at the same time, it was only in sort of more recent literature or more recent data that its effect on the immune system had generated intrigue, because its structure resembled that very close to tacrolimus or FK506. Now, I say recent, however, the works that is in had been part of the citations. So a part of the citations was when sort of the new the new millennium, the early 2000, in around the early 2000, when um when uh when uh when sirolimus or rapamycin had been where sorry more investigations in around sirolimus and rapamycin have been have been um have been in the have been in the literature, or where data in around sirolimus have been evidenced. um at the same time, um sirolimus, it was a new or novel promising immunosuppressive drug towards the rationale, uh, uh, towards a rationale for its use in solid organ or renal transplantation recipients. Calcineurin inhibitors such as CSA and FK506 have been in use for over 2 decades. Although these drugs are highly effective and represent the mainstay of transplant immunosuppression, they are associated with acute and chronic nephrotoxicity. Acute nephrotoxicity, which occurs in the early period post-transplantation, leads to a higher rate of dialysis, and chronic nephrotoxicity may eventually result in allograft loss. Acute and chronic nephrotoxicity is becoming more common, as the use of marginal kidneys for transplantation had increased. MMF or mycophenolate mofetil, MMF and sirolimus have 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 little to no nephrotoxicity. The use of these drugs in combination with other agents or other therapeutics has led to the development of novel paradigms of immunosuppression. These drugs may only be used in acute allografted renal patients or recipients, and may not be used so much in the long term of suppression of allografts. The mechanism of action of sirolimus is distinct from that of CSA and tacrolimus. The latter drugs inhibit the first phase of T cell activation. They interrupt the signal from the T cell receptor by blocking calcineurin. In contrast, sirolimus rapamycin interferes with the second phase of T cell activation. It interrupts the signal from the interleukin 2 receptor or IL-2 receptor and the receptors for other cytokines and growth factors. It blocks the transduction pathway required for the progression of cytokine stimulated T cells from the G1 into the S phase, thus suppressing interleukin driven T cell proliferation. At the same time, that FK506 and sirolimus have the same intracellular target, namely FKB12 protein, whereas CSA binds to another intracellular receptor, binds to another intracellular receptor, cyclophilin, phylline, and at first, this macrolide seemed to be complementary to that of calcineurin inhibitors, and that it would be best in the use with CSA to avoid competition with intracellular drug binding proteins. Works in the illustration, again in the illustration, or in works by Stanislaw Stepkowski. there's an illustration that shows the mechanism of action of sirolimus or SRL or SRL, and this the immunosuppression again works using the same pathway as tacrolimus, thus FK506 binding protein, the complex that is formed between SRL and FKBP, binds to the mammalian target rapamycin or MTOR. The SRL FKBP MTOR complex inhibits biochemical pathways that are required for cell progression through the late G1 phase or entry into the S phase of the cell cycle. Thus, unlike CSA and FK506, sirolimus or SRL blocks cytokine signal transduction, and although the pre-drug sirolimus SRL binds to FK506 binding protein, the complex that is formed between SRL and FKBP binds to the mammalian target of rapamycin or MTOR. The SRL FKBP MTOR complex inhibits biochemical pathways that are required for cell progression through the late G1 phase or entry into the S phase of the cell cycle. Thus, unlike cyclosporin A or CSA and FK506, which block the production of cytokines, SRL blocks cytokine signal transduction. Animal studies demonstrate that sirolimus treatment alters neither renal blood flow nor GFR. The absence of nephrotoxicity had been confirmed in humans and results of another investigation in which sirolimus and CSA were compared as base immunosuppressive therapy showed that 2 years post-transplantation serum creatinine levels were always lower in sirolimus treated recipients. The results also indicated that sirolimus does not induce nephrotoxicity. This at the same time, it was intriguing. It's intriguing and could be a novel step towards reducing nephrotoxicity in paediatric renal allograft recipients post transplant. And randomized studies have shown that CSA and sirolimus combination reduced the number of acute episodes significantly, more so than that with azathioprine. Nevertheless, this brought on intrinsic nephrotoxicity in patients 1 year post transplant, and the results suggest that for still unknown reasons, sirolimus might increase renal toxicity of CSA or cyclosporin A. Therefore, the combined use of sirolimus and CSA had been documented to be avoided in sort of long in recipients longitudinally. Towards at the same time, one possibility at the same time was to use a combination as induction therapy for a few months and then to discontinue CSA. Two such randomized multi-center trials were in early literature were still in progress, and were two such randomized multi-center sort of clinical trials were in progress. This works has not reported the outcomes in around those two sort of randomized multi-center clinical trials as part of this as part of the works. Mycophenolate mofetil, or MMF, or Cellcept was initially developed by the pharmaceutical industry, an organization known as Roche, and is an ester prodrug of mycophenolic acid, or MPA, the active immunosuppressant of MMF. It is used in combination, or has been used in combination, with an interleukin-2 inhibitor like tacrolimus or CSA, plus a glucocorticoid like prednisolone. It is sometimes added with immunosuppressant regimen following the first episode of an acute rejection. However, it should be noted that mycophenolate mofetil agent and it has been evidenced as a prophylaxis, as a sort of prophylaxis therapeutic, and is not effective. In the treatment. Is not effective in the treatment of ongoing episodes of rejection of rejection. Again, in works by Stenslow and Kowalski, there is an illustration. There's an illustration showing a mechanism of action for the prophylactic immunosuppressant MMF. The salvage pathway of purine synthesis in lymphocytes is less active than the de novo synthesis. And so during T cell activation, the activity of both types 2 inosine monophosphate dehydrogenase enzymes and one increase types 2 and 1 increase by tenfold. MMF is converted in the liver by ester hydrolysis to mycophenolic acid, which in turn non-competitively and reversibly inhibits types 2 inosine monophosphate dehydrogenase activity and types 1 and 2 during DNA synthesis in the S phase of the cell cycle. This drug is evidently used or has evidently been used in allografted recipients as a secondary anti-rejection therapy in what is referred as triple management regimen. And so MMF is again sort of used together with, or had been used together with, CSA and prednisolone as maintenance immunosuppression to prevent rejection for renal allografted recipients, and reported adverse effects of the drug included an increased incidence of infection, gastrointestinal disturbances, and neutropenia, so a low neutrophil count. Complications of mycophenolate mofetil limiting its use in pediatric renal recipients. Corticosteroids adverse effects include excessive action on electrolyte balance, metabolism and tissue repair, action on inhibitory effect of sodium secretion of corticotrophin from the adrenal cortex. There is evidence that this drug family causes growth. Unfortunately, can cause growth retardation in pediatric recipients. Antibiotics are also dangerous, as mentioned as mentioned in sort of early parts of this sort of overview. Aminoglycosides such as gentamicins, for example, are extremely nephrotoxic, along with its needed side effects. With its side effects, it can cause the following. It can cause a loss of hearing. It can cause a loss of hearing, sort of clumsiness, unsteadiness, and dizziness. Increased or decreased frequency of urination or quantity of urine, increased thirst, loss of appetite, nausea and or vomiting, numbness, tingling, and or burning of face or mouth, and streptomycin as well. Uh, another sort of another drug therapeutic from the glycoside sort of family, where streptomycin can cause muscle twitching or convulsions, amongst some other sort of reported effects. Although at the same time, some of the effects or side effects are rare, though they have been documented. Um, so as yet, there are no definite or immediate therapies that children or paediatrics can take that can ensure or guarantee sort of a prolonged renal allograft or transplant. Test doses are more applicable for effective suppression and decent treatment. And as mentioned, there is more research required in this in around this specialty, in around this works, and unfortunately, pediatrics or children do not do not do not do not do not do not gain in around the use of immunosuppression. Unfortunately, they learn to tolerate. They learn to tolerate and at the same time can have dramatic side effects. By researching and carrying the relevant carrying out procedures, again. Uh, um, Sort of prospectively, there should be investigations in around linking pediatric nephrology, post transplantation, and in around serology and the in around serology and the major histocompatibility complex, of specific and the use of and sort of the use of pharmacotherapy or therapeutics, and to identify whether it is possible to see therapeutics with reduced nephrotoxic effects, and and so that draws this audio podcast to a close. There will be a subsequent audio podcast that will delve into some more of the sort of some more of the research aspects. This has been an audio podcast as part of the Erythropoiesis edition, an audio podcast as part of the Hurricane Plexar, audio podcast as part of the Labonix Vendip, an audio podcast as part of a Storm Robotics production, and there will be some citations as part of the audio podcast series, where listeners can check out some of the citations and around some of the published works that have related to this, or have been in regarding to this audio podcast series. Thank you.